go after it. And she did that with anemia, she did that with diabetes, and in a natural progression of her effort, she moved from being Senior Vice President of FOGSI, Honorary Secretary of ICOG, to becoming the President of FOGSI. And as a natural progression of that and the commitment to the work that she has shown, she's FOGSI's ambassador to FIGO, and most importantly now is the Vice Chair of the FIGO GDM Working Group, and leads the NCD Prevention Forum. And I think therefore it is very appropriate that she is chairing this session on fetal impact of gestational diabetes, because as we will hear in the course of the 3 talks, while we focus on the monitoring the sugar of the mother, the long-term impact of prevention is possible when we focus on the fetus of the mother with hyperglycemia. So thank you very much, Hema, for so readily agreeing to be here. I also want to thank Dr. Mandakini Megh and Dr. Parag Binawala and ICOG because they were very, very encouraging and very readily gave us one ICOG point, which is definitely something that is very supportive and useful. So with that, thanks. I hand over the floor to Hema to take it forward.
Namaskar. Thank you very much, Uma. I will take the cue from the ICOG point first.
Okay.
Because of her organizational position, the AICC ICOG, it is such a proud showcasing for the South Zone and her position that she holds, not only for the rest of the country, but also to the whole world. And it is that position which got us the one ICOG point. So she's going to talk today about the fetal growth. And truly, from my heart, I have to place on records today that I want to see Uma grow in stature, not only at the local, national level, but internationally as well. So congratulations for doing all that you are doing, Uma, and putting us together on this brilliant program, which I can also give an alternative title, Women for Women. You know, it's a packed panel by the leading lights in the country. And then the story of the ICOG point goes just in the nick of time. Paul reminds us that, hey, we have to get the ICOG point. That's what she's going to talk about today as well. Then, when do you intervene? Not too early. And that is her strength for deliberation on the timely intervention. And last but not the least, Chinmay steps in and says, oh, you guys should have done this long ago. Diabetes, then you wouldn't have landed this baby into so many congenital abnormalities. That was your window to take care. So the early part, you know, the dilemmas that we stumble with, that will be the forte of Chinmay Ratha's deliberation this fine evening. And the sweet people who have joined us all, as Uma said, you have a million other things to do, because somehow in the mind we think there is a lockdown, there is this COVID pandemic, and maybe we can't do a thing. But just look at us. We just twice heaven. There are so many things happening, and that's the way to go. Never give up. We say to ourselves, whether it be COVID-19 infection or diabetes, or for that matter, any other issue related to women's health, to reach every girl, every woman. Join hands with us, ladies and gentlemen, and we welcome you to this session by the AICC ICOG South Zone, headed by Uma Ram. If, for the sake of formality again, I will introduce the speakers today. If Balaji can display the slides, it's fine. Otherwise, yes. The young kid on the block, Chinmay Ratha. Okay, I've really seen her bloom with a very, very focused interest in fetal medicine, and rightly so. Resolution Fetal Medicine Center at the Navodaya Hospitals is what she heads, and the senior consultant at the Yashoda hospital chain in Sikandrabad. She is an approved FMF trainer for the country. We have so few of them. Really, we need Chinmay to the efforts to scale up the quality of training and execution of everything related to fetal medicine. And I'm so proud of you, Chinmay, of the variety of awards that you have bagged way back in 2003 with the CS Don Gold Medal for the best research paper, 2004 for the best paper prize in APCOG, Young Author Award for the paper in Jogi, Rajatre Award in Fetal Medicine, and there is more to come, ladies and gentlemen. That is Chinmay Ratha for you. She would be addressing us, as I said before, what we as responsible OBGYNs should have done to reach out to those who are already diabetic, or they are in the pre-diabetic stage or in the preconceptional stage, where we have an opportunity to get our handle on the issue, making her normoglycemic so that the complications right at the start would be minimized. So we now had Chinmay deliberate on the issue of management of the fetal malformations and early pregnancy care for diabetes in pregnancy. Chinmay.
Thank you so much, ma'am. Thank you so much for the very, very kind words that you have said. I only say that we only sit on the shoulders of giants like you, and we see much ahead because you show us the path that way. So thank you for all the inspiration. And in nutshell, you've actually summarized my talk already. But I will go through this step by step because the topic has been very interestingly coined by Dr. Uma, that it's fetal anomalies in diabetic pregnancies, challenges. That leaves it wide open because, you know, challenge is something we all are very excited about, but very little we know what it entails. Now, before we start looking at the challenge, let's just ponder over a few facts. All of us know them, but at the very beginning, it's important for us to recollect that the incidence of both gestational diabetes and pre-gestational diabetes in pregnancy has increased significantly over the last 2 decades, and the overall burden of diabetes in pregnancy on the society is growing. There are no two doubts about that. Diabetic pregnancies have a high risk of fetal anomalies. We all know that. But only timely detection and appropriate management can help in optimizing the overall perinatal outcome in these cases. These are facts we all know, and actually that's the nutshell of the entire talk. But then in between the lines, there is a lot to be said. Because fetal risks in diabetic pregnancies are a continuum of problems starting from the spontaneous miscarriage in early pregnancy to intrauterine fetal death, congenital malformations, which is the primary focus of today's talk, to shoulder dystocia and birth injuries, neonatal hypoglycemia and infant respiratory distress syndrome, and even long-term clinical effects of gestational diabetes are important contributors to the burden of non-communicable diseases in most countries. But today we are going to primarily focus on congenital malformations. Now, we know about congenital malformations. We know a lot of causes of congenital malformations, and we know that most of these congenital malformations affect about 3% of live births in the regular population as well. But the pathogenesis of a majority of this is unknown. We really don't know which factor contributes to how much of congenital birth defects. Nevertheless, pregestational diabetes is one of the leading known causes, and it increases the risk of birth defects 9-fold compared to that in non-diabetic population. So here is a factor where most of the factors are unknown. Here is a factor which increases the risk 9 times as compared to another pregnancy where this factor does not exist. Why does this happen? Because the most important factor leading to teratogenesis is presumed to be the hyperglycemia, the increased glucose in the plasma of the women who have uncontrolled diabetes leads to certain changes at the cellular level. There are functional deficiencies of important metabolites like arachidonic acid and inositol. There's inhibition of cellular uptake of the dehydroascorbic acid, increased non-enzymatic glycosylation of embryonic proteins, decreased catalase activity, increased substrate-induced free oxygen radical production with abnormal levels of trace metals. Now, all these sound very complex, but if we remember our basic biochemistry, these are the factors which lead to the free oxygen radical production, which leads to oxidative stress injury at the cellular level. And therefore, it all boils down to decreased cell proliferation, increased cell apoptosis, that is programmed cell death, and altered gene expression, which causes deviation from the normal developmental process. High oxidative stress. We all talk about free radical injury, but what you have to understand here, that free radical injury may arise from simple metabolic problems like hyperglycemia. I saw an interesting paper where they said even the neural crest migration, we know neural crest migration is extremely important in organogenesis, and even this has a metabolic reprogramming associated with it, such that neural crest cells display the metabolic adaptation known as the Warburg effect, and enhanced glycolysis is required for the neural crest epithelial to mesenchymal transition. So wherever there is a problem with the glycolytic pathway or the glucose metabolism, all these basic cellular mechanisms can get affected, and therefore organogenesis can get affected. So the pathophysiology may be complex, but it clearly relates to the maternal glucose levels. Now we have to deal with clinical challenges. Whatever we talked so far is our basic theoretical knowledge. We are all good at that.
Chinmay, we seem to have lost your audio. Yeah.
The challenge one she was mentioning, and this is already, the challenge is evident.
Chinmay's
Minute for Uma to contact Chinmay and back.
Yeah, I'll call her.
And meanwhile, there are a whopping 182 participants. We are happy to welcome all of them yet again. And the program that has been put up by Uma is such a smooth sequence on where we start, how they affect in the early part of the pregnancy, how the growth impacts when you're expecting a large baby. Suddenly you may find a growth restricted baby, and you have taken all the efforts to sail this pregnancy right through. And for some reason you're in a dilemma. Am I intervening at the right time? Is it too early, too late? Because just one decision of yours can make or break the case. So we have been having very special problems in the COVID era as well, because the standard practice for antenatal care is to keep to the antenatal visits to the minimum. In fact, when it started, we said just 3 visits. Rest of it, video call and chat, and somehow from distance you manage your patient. But that liberty is not allowed, dear friends, for those with comorbidities, especially the gestational diabetes and gestational hypertension. These are the patients you will have to, by default, call them over and over again when you think it is necessary, because there is a lot that you can miss. But the digital technology comes to our rescue when you have to chart her daily sugars, for example, or in a sudden state of either hyper or hypoglycemia, the patient can chat with you. Now, telemedicine is legalized and approved by the MCI as on 25th March 2020. So we can offer them the advice on the blood sugar levels based on their chat message or a video consultation that you may offer. So we hope to have Dr. Chinmay back.
Hello, ma'am. I'm really sorry.
Yes.
Apologies. I don't know.
No, not an issue.
No,
so we just fill in the blanks. Go ahead, Chinmay.
Thank you so much, ma'am. So as I was saying, the first clinical challenge we have is answering questions which our patients pose in the OPD. So this is Mrs. Sweet one, married life 12 years, but she gives a history of PCOS and
Chinmay,
infertility
you may want to,
treatments that failed in the past.
Yeah, go ahead.
Seems to be a network issue.
Hello?
Yeah, can you go ahead, Chinmay? We can hear you
Yes,
now.
yes. Okay. So the remaining antenatal care panel reports are all. A scan was done and she's 6 weeks, 4 days with normal fetal heart. Now the patient asks, will my baby be healthy? So she has an HbA1c of 10.7% last week. So what is the answer that we can give her? Can we say her baby is going to be healthy? We know that maternal hyperglycemia is the primary teratogen. And the way it works is, we discussed oxidative stress, transcriptional changes, and epigenetics. And this is a woman with proven hyperglycemia in the periconceptional period. Periconceptional HbA1c is used as a surrogate marker for glycemic control and is very closely related to the risk of major fetal anomalies. So this was a study which was done and found that if the HbA1c was greater than 10.1%, then there was statistically significant higher occurrence of congenital malformations. Now, what do we do? Mrs. Sweet One has an HbA1c of 10.7% and she's come to us at 6 weeks, 4 days. She's definitely at high risk of anomalies. Should we even advise her to continue the pregnancy? I mean, as of now, we are not able to interact one-to-one, but you can put it in the chat box. What do you think? Do you think that she should be continuing the pregnancy, or would some of you even consider termination of this pregnancy because her HbA1c is 10.7? Unfortunately, we still have such kind of advice doing the rounds in the clinical circles, because patients do come for second opinions where they have been advised to terminate a pregnancy because the HbA1c is more than a certain value. Now remember, this is again high risk. It is high risk, but it still has the scope of normalcy, and hence we will not advise termination based on raised HbA1c alone. There is a challenge here. The challenge is to find out whether or not there is a structural defect. The point is, are we up for the challenge? So with our knowledge of the teratogenicity and the types of organ systems that can get affected with hyperglycemia, we try and revise that what all systems we need to check before we can reassure Mrs. Sweet One that things are going to be fine for her. So the most common system affected during gestational diabetes is the cardiovascular system in terms of fetal anomalies. And the commonest abnormalities that are seen are things like transposition of great vessels, ventricular septal defects, atrial septal defects, coactations, cardiomyopathies, and the single umbilical artery, which is now considered a part of the cardiovascular system. In the central nervous system, we can have open spina bifida, anencephaly, microcephaly, or horoprosencephaly. Facial clefts are common. In musculoskeletal system, we could have a caudal regression, sacral agenesis, or limb defects. Renal problems could be there. And similarly, GI abnormalities are also common in fetuses with diabetic mothers. So this is a checklist of structures that we need to see before we tell her that the baby is normal. And we also alert her that these are the problems that can happen to her fetus. So the next step that we take is to call her for a
Mr. Balaji and team from
12-week anomaly scan,
delegates,
because we will be able to at least do a comprehensive run-up for the presence of the skull, the orbits, the profile of the face, absence of any anterior abdominal wall defects, presence of a fetal bladder indicating normal functioning kidneys, the presence of a stomach bubble indicating the patency of the upper GI tract, presence of normal limbs and normal kidneys, along with a 4-chamber view of the fetal heart. What is more specific that we need to see if the woman is at risk of anomalies due to fetal diabetes, maternal diabetes? We just realized that fetal heart abnormalities, especially the transposition. So in the fetal heart assessment in first trimester, if the mother is diabetic, we insist that you should look at the V sign and the Y sign. Those people who do fetal medicine and understand imaging at this point will understand that these two signs will indicate a normalcy of the outflow tracts and give us a good reassurance, because a normal 4-chamber view is part of a routine assessment in first trimester. But because the mother is diabetic, it would be good to add on the V sign and Y sign to the assessment. Similarly, in assessing this mid-sagittal section of the upper face and neck, it would be good to assess what is called the intracranial translucency. This is a feature which is seen in the same view as the nuchal translucency, and it indicates the future cisterna magna and if the future fourth ventricle. So if that is collapsed in the first trimester, that gives an idea that probably this fetus is at high risk of open neural tube defects, and therefore this fetus can be called early, around 16 weeks, to confirm the neural tube defect if it is not completely apparent at 12 weeks. So after this extensive scan, Mrs. Sweet One asked, so doctor, can I be reassured now my fetus has no anomalies, no aneuploidies? So you've done the 12-week scan, you've seen everything is normal. This is a woman with an HbA1c of 10.7. Can you reassure her at 12 weeks that everything is fine and now there's no need to have any more surveillance? You will still start faltering and you'd want to say many things, but you don't know what to say, because if you say too many things, you will freak her out. And if you don't tell her enough, you will actually not give her enough information. So sometimes the questions are complicated, but the answers are simple. So use the traffic light system and tell her what is green, what is yellow, and what is red in her situation. What is green in her situation is, yes, the basic anatomy assessment for this fetus is normal till this stage of gestation. So that's great. We've ruled out many problems, at least like anencephaly or exomphalos, but we will review again after a few weeks to check that the organ systems have developed as they should progressively. And we need to get composite screening tests done for the risk of aneuploidies. Yes, nuchal translucency is normal, but that alone is still incomplete, and we need to do the biochemical screening. Remember the disclaimer at all times that scans and blood tests cannot rule out all anomalies. Having said that, the combined first trimester screening test is a very good method of offering screening for aneuploidies in the first trimester, and doing it all with the protocol as suggested by the Fetal Medicine Foundation, we could achieve a sensitivity of 95%. So when you subject a woman with diabetes to a combined screening test and at serum biomarkers, the levels of serum biomarkers generally appear to be lower in women with hyperglycemia than euglycemic women. And therefore, specific adjustments have to be made in the software to calculate the risk of aneuploidies in these pregnancies. So make sure that the lab which is taking your biochemical markers for a diabetic woman is taking into account that fact. Otherwise, the risk assessment would be erroneous. Should we review a woman who has had high HbA1c in first trimester, but a normal 12-week scan? If there were no doubtful findings, then you can see her at 18 to 19 weeks. But if there were any doubtful findings in the first trimester, it would be useful to call back 16 weeks. The rationale is open would be apparent at 16 weeks with a good scan, and an early diagnosis would allow a definitive plan for either further testing or termination, as the case may be. But if there are no risk factors, it would be better to call her back around 18 to 19 weeks, because cardiac and CNS abnormalities would be better evaluated in detail in a later gestation. But since we have the 20-week cutoff till the law changes, there is still time to test or terminate if we have seen her around 19 weeks. So at the 19-week scan, which is also known as the targeted imaging for fetal anomalies, what is it that you're going to specifically look in a woman who has diabetes? In the head, you always look at the standard views, the view and cerebellar view and cerebellum in the first trimester, but for whatever reason, if it's not seen, it cannot be missed in the second trimester. Holoprosencephaly is a problem where there is incomplete cleavage of the forebrain, and therefore you see a complete like a fused ventricle in the forebrain there, and that should be detected here. Unusual protuberances from the brain of the fetus like encephaloceles should be detected on this scan. Similarly, if you look at the spine of the fetus and you unusual branches here, these are indicative of open neural tube defects or open. The corollary markers can be seen in the fetal head and brain, where you see ventriculomegaly, lemon-shaped head, and a banana-shaped cerebellum. Then come to the fetal heart. When you look at the fetal heart in a diabetic woman, four chambers, the complete development of the heart might be complete when you cardiovascular assessment. Once you do all the entire assessment, you are good to detect almost 85 to 90% of the cardiovascular defects that are expected at this stage. Some of the problems with regard to diabetic pregnancies could be related to the situs or abnormal arrangement of organs in the fetus, and that also can be detected by a comprehensive evaluation. The situs of the fetus. Sometimes you will start the diabetic pregnancy. Depending on what is the kind of cardiac abnormality you detect, you involve the pediatric cardiologist, you involve the neonatologist, as well as the endocrinologist, and form a multidisciplinary team to decide the neonatal period and what should be the follow-up.
Can I just make a request to all the delegates to
in the abdomen of fetuses,
we will be able to hear the audio better. Thank you.
Very common. Dilated bowel loops, hydronephrotic, that is your indicator for future problems. And the abdominal cord insertion will help you rule out any kind of anterior abdominal wall defects. So if there is a defect, it will be seen and documented. If you see a double bubble sign with polyhydramnios, that could be a marker of GI obstruction like duodenal atresia, as well as of aneuploidies like trisomy 21. So all this have to be carefully documented in a fetus with a diabetic mother. So this is renal agenesis. Nowadays we have very good color Doppler technology, and in case of doubt, because the shadows of the kidney and the rest of the abdomen are sometimes very similar, and there could be a scope of doubt. So in those cases, you can run a color Doppler. In the absence of renal arteries in that color Doppler signal would indicate bilateral renal agenesis. Or you could see dilated kidneys like this, which indicate hydronephrosis, which may be because of lower urinary tract obstruction. The limbs, as you can see, the ultrasound machines can give you beautiful pictures of the limbs, and you can reassure yourself that the limbs are growing well. But sometimes there could be abnormalities. For example, here, where you see an abnormal curvature of the fetal foot, and this is nothing but a talipes or a club foot. And this is also common in women who have in fetuses of diabetic mothers. Now, when you have an abnormal fetal structure, what is that? You have to detect whether the abnormality may not make sense to continue the pregnancy, or it is a correctable abnormality, so that you can offer a complete workup, multidisciplinary counseling, and plan further care in that fetus. One common problem with diabetic pregnancies is cleft lip and palate in the fetus. And this is an example of a very good correctable abnormality. With postnatal surgery, the results are excellent. Now, in our unit, we have a very sturdy method of introducing the patients with fetuses who have this problem to the future caregivers. So in Nizam Institute of Medical Science in Hyderabad, they run a government program, and there's a lot of benefit that the patients can derive from. Now, what we arrange is a prenatal counseling with this team for postnatal repair, and that gives a lot of confidence to the parents that things can be handled after birth. So they are given a timeline of the kind of problem that they have and when the correction is expected to happen, and therefore this empowers the family or whatever is required in future and effect of correction, and they get better. So when there is a correctable abnormality, we try our best to help the parents with making their decisions and continuing the pregnancy towards a better outcome. So the clinical challenges after detecting an abnormality is to find out what is the abnormality, what are the associated features, what is isolated or multiple, lethal or correctable, what is the time of diagnosis, the gestational age, what are the facilities for perinatal care, and the attitude of the parents. So having taken into account all these factors, if we rationally take it step by step, we can take every fetal anomaly to its logical ending. Now, suppose we see normal fetal anatomy
I think we've completely lost Chinmay's audio. Is that correct?
Yeah, I think so. I think there is some problem at her.
Yeah, because Chinmay kept on saying another challenge, another challenge. It's the same we're facing many times. Yet again, yet another challenge. So she's taken us through some of the situations of dilemma to an OBGYN when we can't give them definite answers. And at every meet, we are asked the HbA1c. You say the cutoff is so and so, but what if the patient presents with a higher HbA1c? What do we tell her? Should we really tilt our judgmental decision making towards not having so many problems later and just, it's an all or none. If you terminate the pregnancy, then you have nothing to look for. So, but that is not the correct, and it's not an easy decision to place, because most of the patients, luckily for us today, have stopped saying that you decide. So it is our opportunity to tell them, these are the facts. This is what is available in literature. Then let's take you through the pregnancy. And that's why Chinmay's topic is so very important, that you ought to have done something before the embarking on the pregnancy. And worse still, dear friends, first time there has been a calamity like that, and you know that there is an 80% chance that she will get into a hyperglycemia in her next pregnancy as well. But he has told her anything, and not even the contraception is advised, or no, nothing. And then she comes back again with the same story, and that we have to take the onus on us. Chinmay, can you now hear us, my dear? No, you're muted.
Sorry, ma'am. Yes, ma'am.
So you were at 19-week slide.
Yes.
And you said there's yet another challenge. Tell us what.
The challenge also.
There are too many
you should
challenges.
be able to see the fetus with the kind of clarity that Chinmay has shown us. Because if you have a woman with the BMI of 38 or 40, it's going to need an expert to get that level of imaging done as well. So,
thank you, ma'am. But the machines are getting better and better. And I think that is another message very rightly pointed out by Dr. Uma. These are the women who need to be seen by focused machines.
Specialists.
And there are very good machines now available. So upgrade your technology, upgrade your machines, and give the best to your
and the eyes that see the image also.
Yes, that also.
Absolutely.
Absolutely.
Yes.
So the thing is, even after we have seen a 19-week fetus completely normal without anomaly, we cannot be assured, because this constant hyperglycemic stress on the fetus can lead to problems like hypertrophic cardiomyopathy. You may have a condition where your heart was normal at 19 weeks, but by 32 weeks, you see the muscles are hypertrophied and the heart is not looking as healthy as it would otherwise. So, and GI obstructions, they may not start later, but they may manifest later. Macrosomia, I'm sure Madam will talk about it in the next talk, and that associated polyhydramnios. So all these things can, again, change the fetal prognosis. And in addition to that, maternal comorbidity like pregnancy-induced hypertension and preterm birth. Why am I talking about preterm birth? Because suppose we have reassured somebody with a transposition of great vessels. It has a very good outcome. Pediatric cardiologist has said, excellent, we are in Hyderabad or Bangalore and Kolkata, we can always treat them. But suppose the baby gets delivered at 30 weeks for some reason, then the entire prognosis changes, because now prematurity becomes the riding factor. Cardiac surgery doesn't function very well in premature babies, and then things go wrong. So the fact remains that fetal surveillance in a diabetic mother, you have to balance the odds of so many confounding variables. You look 4 weekly for growth and Doppler in the 3rd trimester. Watch out for evolving fetal anomalies in the cardiovascular system or GIT, and strict control of maternal sugars and surveillance for pregnancy-induced hypertension. So there has to be a perinatal care team in place to manage fetal anomalies, and that's another challenge, to have a multidisciplinary support system to manage these kind of fetuses. Now, GDM leads to adverse long-term effects, including a higher risk of developing metabolic disease in the mother and the child. So infants of mother with GDM, they showed lower mental and psychomotor developmental indexes compared to infants of non-GDM mothers at 6 months of age. These are various studies where they compared the women who were delivered with hyperglycemia and babies who were delivered of euglycemic mothers. And they saw there was a trend towards lower IQ scores, lower performance in school in the children who were born to GDM mothers. This was also associated in some studies to the low levels of DHA, but giving DHA alone does not help, because it's the hyperglycemia which creates the problem. So it's not the availability of DHA there, but it's the availability at the cellular level, which is again altered by the hyperglycemia. So all these factors lead to a poor long-term neurodevelopmental outcome for GDM fetuses of GDM mothers. So the challenges for fetuses in a diabetic pregnancy never seem to end. At 12 weeks, you're still thinking. At 19 weeks, you were again thinking. All the 3rd trimester, you thought about it. You delivered her, but you're still not happy. So what to do? It's not knowing what to do. It's doing what you know. So what are you going to do now? You know that prevention of fetal anomalies in diabetic pregnancies can be prevented by preventing the hyperglycemia. And that was what Hema ma'am said in the first place. And that's why I said that was the gist of the talk, that most of the studies have shown that stringent control of glucose prior to the early pregnancy or during organogenesis can significantly reduce the incidence of birth defects. That brings us to the very important concept of preconception care. And there is enough evidence now to say that women who were educated about this in the preconception period, who took care, who took therapeutic interventions well in advance to reduce the hyperglycemia in the periconceptional period, had good outcomes and a significantly lower incidence of fetal anomalies. So the challenges for fetal anomalies in diabetic pregnancy is recognizing that there is a rising incidence of diabetes. So every woman whom you see in the reproductive age group, you need to alert her about her glycemic surveillance. I mean, at least let her check that before she plans to get pregnant. Detection of the at-risk fetuses. By chance, there's a woman who comes, like our patient here, with a 10.7 HbA1c. That's an at-risk fetus, but that's not an indication to terminate that pregnancy. That's an indication to hold on and move on. She was 34-year-old with a 12 years married life with that history. So probably you were all happy that we continued. But if she was a primary gravida with a 2-year married life, many of us would have said, oh, why take the whole stress and terminate? But the ultimate outcome could be good even in these cases. Optimum surveillance for fetal development throughout pregnancy, management of fetal anomalies if they are detected, and other issues of confounding outcome like prematurity, comorbidity, and general metabolic issues affecting the neuro outcome should be taken into care. But everything said and done, prevention is much better than cure in these cases. So when you have to prevent, what you need to do, optimize the preconceptional sugars and early booking and timely antenatal care, which can lead to healthy mother and a healthy fetus. Thank you very much for your patience, and apologies for the constant technical glitches that were coming on. Thank you.
Thank you so much, Chinmayi. Again, the last slide saying prevention is better than cure, whether it be diabetes or whether it be COVID-19 infection. So that is the key which has changed the mindset of many in our own country, because health is wealth is what they have recognized, and the preventive aspects have got much more sensitized in people's heads than ever before. Thank you very much for a wonderful presentation. And in keeping with the title of your talk, you did face many challenges and faced it brilliantly. And when we talk so much about the mental health issues around this corona pandemic, so much the mind had been stressed, the peak is over and the calm has come. And you have asked us to be calm, so we will. And move on with the next presentation. Chinmayi, to stop sharing the screen. Yes. Yes. Then we bring on the next stalwart on to the ring, Dr. Umaram. Now, what can I say? The work and the thoughts converted into action speak for themselves. Very quickly, she put the team together, made us into a nice string of programs which are key points for deliberation. And today, as I said, she may be holding the chair of South Zone AICC-RCOG, but tomorrow it'll be something much more bigger and better. And she needs to reach people all across and to do more, to showcase how we in our country are doing our best despite the time constraints, despite the technical and technological challenges. Archana Baser very rightly said, focus on the machine is what Chinmayi said, but we also need to focus on the person who is using the machine, which was followed up with Uma's comment as well. So in the leadership position, all these potential thought leaders will bring in quality training as well as the best of the machines into the country, I hope. As a director and consultant at the Sita Clinic and Hospital in Chennai, having won the Gynecologist Award at the AOFOG, Asia-Oceania region. And also, it's good for us to break the silos, cross-connect with groups other than OBGYNs, such as the Rotary, and she's got the Women Achiever Award in the Rotary. So the achiever in the making, we wish you the very best for many more accomplishments to an already well-accomplished, distinguished gynecologist, whom we present to you, ladies and gentlemen, Dr. Umaram, who will take us through the swing that the fetus can go through. The mindset is that we may expect a macrosomia, but I'm sure that she will deliberate on the other extreme of the spectrum as well. What if we get unexpectedly a growth restricted? How do you manage these challenges? So we have Dr. Umaram with us to speak about fetal growth, which is one of the key elements for tracking. When we track the sugars of the mother, we track the anomalies and the growth of the fetus. So this is again an important segment of the care of hyperglycemia in pregnancy, and we present to you Dr. Umaram. Go ahead, Uma.
Thank you very much, Hema, for that very generous introduction. I'm very happy to talk about fetal growth in diabetic pregnancies because it merges two interests of mine, both fetal growth and diabetes. Besides that, I think it's important because, as Chinmayi said, and as we all know, at least 1 out of 5 or 6 women who walk into our clinics have hyperglycemia and pregnancy. Now, majority of this hyperglycemia is related to gestational diabetes that happens during pregnancy, but a percentage is because of pre-existing diabetes, which is not detected earlier and detected for the first time. Now, when you look at aspects of fetal growth, you know that there are some fetal growth rules, that every fetus has its own growth potential. And this growth potential is influenced by a couple of factors. And these factors that determine the intrauterine growth trajectory are its own genetic potential, what the baby starts off with, substrate availability, and endocrine regulation. Now, if you think about hyperglycemia and pregnancy, we automatically can see that all these three factors get affected in that condition, because if a fetus which is growing in a mother who has herself hyperglycemia or been exposed to hyperglycemia in utero if her mother had gestational diabetes, then it's already affecting the genetic potential of this fetus. In addition, when the sugars are high in this pregnancy, it impacts substrate availability, and obviously gestational diabetes or diabetes is a condition of endocrine regulation. And all of us who have taken care of diabetics in pregnancy, because it's so common, all of us manage it, you can see that all these three kinds of babies can be born. You can have this large macrosomic baby, you can have a runt growth restricted baby, and you can have a normal baby also born to a diabetes. Now, the other thing that we also have to keep in mind is the fetal mass is a reflect of the environment, that is the fat mass. But the fat-free mass is what is influenced by genetic factors. And this is something that we need to keep in mind. Now, we are all very familiar with Pedersen's hypothesis, where we know that the maternal hyperglycemia causes fetal hyperglycemia. This induces fetal hyperinsulinemia. This increases IGF, and that is what results in overgrowth and organomegaly. And this is something that we have learned from our postgraduate days. Now, we also know from studies, the classic one being the HAPO study, that the association between sugars in pregnancy and outcomes are a continuous association, and there is no single threshold below which there is less adverse outcome and above which suddenly there is a dramatic increase in the adverse outcome. So it is a continuum, and whatever cutoff we use in order to label a woman as gestational diabetic is a cutoff that we have used, saying above which we will consider it abnormal. It does not mean that below those levels there is no impact on the fetus. Now, fetal growth is directly impacted by hyperglycemia, and there is a lot of data to suggest that with increasing plasma glucose on the OGTT, there is a direct correlation with macrosomia and cesarean sections without, as I said, a clear threshold for increased risk. Now, the important thing in hyperglycemia and pregnancy is that the growth is disproportionate. And it is disproportionate because there is an increased layering of subcutaneous fat. Now, this increase in subcutaneous fat is seen even when there isn't macrosomia. And this is a fact that we all have to actually internalize, because you could have a baby with normal weight still having abnormal fat distribution. So our traditional concerns with hyperglycemia and pregnancy to do with the fetus in terms of growth are weight, and because of weight, birth trauma, difficulty in delivery, shoulder dystocia, and immediate neonatal complications. But we know that these infants of mothers with GDM have an increased insulin resistance. This increased insulin resistance actually results in an epigenetic change in utero, and this epigenetic change sets the stage for long-term alterations in fetal fat distribution and metabolic changes, which these babies actually take with them into adolescence and adulthood. So as our understanding of DOHAD, or the developmental origins of health and disease, have improved, we know that a small change in this environment may permanently alter the working of genes. So when we look at fetal growth, and this is something that has been reiterated in multiple forums, it is important to look at the growth curve or the growth centile, and not look at weight or abdominal circumference as a single point. So we always have to see what has happened in comparison to where this baby was before, and this growth trend is more important. And obviously, if you have a macrosomic baby, it's a baby that can cross growth centiles even without exceeding that 90th or 95th centile, which is the classic definition of macrosomia. So you could have an abdominal circumference that goes conformed to the mean and another pattern where there is accelerated growth. This accelerated growth happens because there is more deposition of subcutaneous fat. Now, traditionally, if you see, studies largely from the West have shown that until 26 to 28 weeks, actually the growth of the head, fetal head and the fetal femur follows a very similar pattern to normal fetuses. And it is only after 28 weeks that there is an increase in the abdominal circumference, resulting in an increase in the weight. And this was seen in many studies, including by Langer. Now, this publication by Savio actually said that if you look at, they looked at a fair number of babies, 4,000 odd babies, and they said that when they saw these babies at 20 weeks, there was no variation in growth. But between 20 weeks and 28 weeks, actually, there was an increase in growth. And because their screening was done only around 28 weeks to pick up gestational diabetes, they said that the acceleration in fetal growth actually preceded the diagnosis of gestational diabetes. So we'll come back to that growth pattern in a bit. So when you look at the fetal growth pattern in gestational diabetes, you can have, this is a woman who had normal sugars at booking. And then you can see that here at 20 weeks, you can see that this baby is actually already on the bigger side on all parameters. The BPD, the HC and the AC are already somewhere in the region of the 70th centile. And this is also the power of the growth chart, because irrespective of what these individual values are, the moment you plot it against a curve, you know where this baby is heading. Now, this woman's booking sugars were normal, but when she underwent her glucose challenge in at the 24th week visit, she was diagnosed to have gestational diabetes. And then this, even though her control was good, this growth trajectory continued to be on the higher side. The only point we can make is if her growth, because her glycemic control was good, this growth trajectory continued in this fashion along the upper limits. Whereas if it had been a poor control growth, you would have expected an acceleration coming somewhere there. So here is another fetal growth pattern. You can see that actually the abdominal circumference and the fetal weight growth are reasonably in the normal ranges, somewhere around the 50th centile. And then you see an acceleration of the abdominal circumference and the fetal weight actually going and hitting the 95th centile. And here this woman actually had was again somebody with gestational diabetes. The control was initially not optimal, and then going forward, the glycemic control tightened. But despite subsequent tight control, you cannot change that trajectory of fetal growth because the fat deposition has already happened. So if you allow a certain period of time where the glycemic control is less than optimal and there is persisting hyperglycemia, that deposition of fat cannot be undone. And therefore, after the tendency to go up in fetal weight or the fetal abdominal circumference is seen, subsequent tight glycemic control cannot change the trajectory. Now, what is happening here? Equally, we cannot assume that there can be no small baby in a diabetic. So in this growth pattern, this was somebody who actually was seen and diagnosed to have gestational diabetes at her 24th week scan, but GCT, but you can see that this baby is actually hugging the 5th centile. And it's getting smaller and smaller. And in this situation, here, when we went back and looked at her growth, we found this baby was continuing to be small. And so we sat down and asked her, because she was somebody on her diet, and we realized that actually the control, if you look at her pattern of sugars, the sugars were consistently in the lower ranges. In the 70s, everything was below 80 in the fasting, and everything was only around 110 or 120 at a 1 hour value in the post meal. So a little bit of relaxation and continuing monitoring of the sugars, you can see that the sugars, abdominal circumference is tending to go up. But of course, at this point, one has to ensure that there is no other reason for a growth restricted baby when you see a baby that is hugging the 5th centile. If there are no other risk factors, then look at the sugars, because traditionally what happens when we have somebody who's on medical nutrition therapy, we tend to check their sugars once a week or once in 2 weeks. We are really not monitoring them as intensely as we would monitor somebody who's on insulin or somebody who is known to have much higher sugars. So here it is important to look at the baby, because we need to look at the baby and the mother, not just her sugar parameters. So if you have a baby that is small, also even though the mother is only on medical nutrition therapy, get a 4-point or a sugar for at least a week or 10 days and ensure that she's not under very tight control. Now here is another situation where you have a baby that is growing, and then suddenly you find that the growth is tapering off. And what can happen there? Here you need to worry about, is she at risk of developing preeclampsia? I've just zoomed that chart a little bit. When you find growth dropping off so much here, you have to worry about whether there is growth restriction happening, superimposed preeclampsia and from placental dysfunction, because we know that women with gestational diabetes are at a much higher risk of preeclampsia. And we also know that fetal growth changes can antedate the increase in blood pressure, which will show up sometimes a week or 10 days after we pick up the fetal growth. So there have been studies which have looked at actual levels of glucose, and this one from Langer shows that for every 10 milligram decrease in the sugar, you can have an increase in the chance of SGA, and for an every 10 milligram increase in the sugar, you can have a 14% increase in LDA, and the prescribed optimal target as per that paper is between 87 and 105. So the point I'm making is, how good are we at monitoring control? We tend to monitor control by looking at the woman's sugars, as we should. We should look at her sugars, but there are some situations where we need to look at the sugars a little bit more carefully, and we also need to monitor the fetus, because that is the baby that is being affected by the mother's hyperglycemia. And this was a paper from 2007 from Kejos's group, where they actually used the abdominal circumference to modify glycemic therapy, and found that when the abdominal circumference was greater than 75th centile, they lower the glycemic targets and intensify therapy. So the other factor that we have to keep in mind is that there is a nexus between high BMI or maternal obesity, GDM, and not just pregnancy, but beyond pregnancy. We know that the higher maternal pre-pregnancy BMI and a higher pregnancy weight gain is associated with an adverse adolescent cardiometabolic profile. And this association is largely mediated by adolescent BMI. So here you can see, when you say diabetes begets diabetes, this is what is happening. So this is a mother with high BMI, having hyperglycemia, has a baby going inside her. That baby has abnormal fat deposition, becomes an adolescent with metabolic problems, and therefore the chain continues. So here, which then brings me to the issue that while we talk about birth weight, we need to also think about weight as a composite weight of fat and non-fat weight. And it is the fetal fat mass that predisposes to obesity and type 2 diabetes in adult life. So as I said, the issues with fetal weight are that it's a crude estimate. And therefore, there have been a renewed interest in studying fat composition in diabetic pregnancies. And they have found that even when you take appropriately grown infants of GDM mothers, there is an increase in fat mass, increase in body fat percentage, and skin fold measures. And I want to draw your attention to the fact that fat-free mass was significantly less. And this is something that is important for us as South Asians to remember, that they've looked at different things. They've looked at shoulder fat, they've looked at abdominal wall fat. Now, this is data from looking at South Asians. Now, here, if you see, they compared Southeast Asians, South Asians, Middle Eastern, Pacific Islanders, and you can see that the South Asian birth weight is the lowest, but their mothers have the highest glycemia. So in a South Asian population, the fact that our sugars are high does not automatically mean that our babies are going to be bigger, but it does mean that our adiposity distribution is likely to be different. And there are many papers that have looked at it. The first indication of this, of course, is way back in 1991 when Professor Yagnik described the phenotype of the thin fat Indian, and then subsequently in 2003 showed us that the thin fat Indian baby is even at birth, our babies have more adiposity. Now, our own data, though retrospective, showed that in our babies of mothers who subsequently developed GDM, the abdominal wall thickness, which is a surrogate measure of abdominal fat, is increased at the 20th week scan in women whose booking sugars were normal and subsequently went on to develop GDM. Of course, this is now undergoing prospective evaluation. So if you're smaller and are born with more adiposity, that's really not a very good place to start. Now, this was another study that was published, I think, 2019. It looked at different patterns of growth trajectory between European and Asian mothers, South Asian mothers. And this is what happens. This is the, I hope you can see my pointer. If you take this to be the average European baby, you can see that the South Asian babies in general, this is non-GDM mothers, is smaller. Now, if you then look at what happens to our babies, this is what happens to mild GDM in South Asian in that stock cohort. And this is what happens to moderate and severe GDM. You can see that in the babies which of mothers who have moderate to severe gestational diabetes, the babies start off being much smaller than the non-GDM South Asian baby, which is this dotted line. In comparison to our own non-GDM, our GDM babies start off being smaller and then they grow bigger. And whereas that we don't see in our mild GDM, they are just on an average slightly bigger than our GDM babies. Now, if you take ethnic Europeans, however, the pattern is not so different between the mild GDM and the moderate GDM. So much so, depending on ethnicity, there is a difference in fetal growth patterns. So we cannot automatically assume that everything that the Western world is talking about fetal growth in diabetes is applicable to our population, because our population seems to have a different kind of a response to the hyperglycemia in utero. So this was the most recent studies, which publication from the Lancet Endocrinology and Diabetes in the March of this year, where they have said that gestational diabetes was associated with a larger fetal size even at 20 weeks. It was not statistically significant, but the difference in size was already there. And then it became more significant at 28 weeks. And this was in a cohort that they studied in the United States, where they actually screen only at 28 weeks. And therefore, they actually said that in order to mitigate gestational diabetes related fetal overgrowth, we should start screening early. Now, that's one good thing that we're all doing, and Hema has been the driving force for that, that we are actually screening our mothers very early. Are we too glucose-centric is the last thought that I want to leave you with, because there have been large number of publications which correlate triglyceride levels and low HDL cholesterol levels with increased birth weight, higher risk of LGA, and a lower risk of SGA. And we do know that at least our older women are, and as a population, we are more prone for dysglycemia. We are not testing that for pregnancy as yet, but here is another area where a lot of research can be done. So especially if you have women who are prone for dyslipidemia, women who are obese to begin with, in these women especially, and are we watchful enough when we are monitoring their pregnancy? Are we just looking at one sugar value and saying they're okay? Or are we doing a comprehensive evaluation of the impact of the hyperglycemia on the pregnancy by watching how this baby is growing also? I think that is a question that we need to keep asking ourselves. And we need to monitor fetal growth because it reflects glycemic control. It has value in prediction. It has implications for treatment. It helps us anticipate neonatal problems, and it helps us anticipate adolescent metabolic issues. And in pregnancy, we can only anticipate, but in early pregnancy, we can actually help prevent by identifying. So this is the protocol. We need to monitor growth at 28 weeks. If you go by the NICE guidance, they'll say every 4 weeks after that. May not be practical in all situations in India, but at least one more at 36 weeks. But what is important is to look at the trajectory of growth and possibly look at fat assessment, because the story is not just about birth weight, but about fetal programming. And this is the comment in the same edition of Lancet, where they say that obesity begets obesity, diabetes begets diabetes. And neonatal fat and not birth weight is associated with childhood obesity. And therefore, reducing neonatal obesity should be one of the aims of public health efforts. So preventive strategies after the diagnosis of GDM, even if we screen early, may be too late. So we definitely need to screen at booking in our population. We need to initiate preventive measures in those women who we believe are at risk, because reducing their sedentary time and modifying their diet may actually help us prevent them from developing hyperglycemia going forward. And that is the only way that we can prevent the adiposity deposition in the fetus, because in the NCD prevention agenda, timing is everything. And starting after the baby is 12 or 15 may be way too late for even the next generation, forget this generation. So I think that is a mental shift that we have to make, because we are in a unique time in medicine where we can predict future disease and prevent it across a generation. Thank you very much.
Thank you very, very much, Uma, for such an insightful presentation. And the question that she posed, ladies and gentlemen, is, are we watchful enough? And we also have to ask ourselves, do we know enough? Are we doing enough? There are a lot of structured, unstructured, flexible thought processes with a variety of organizations. And it's so crucial for us to be on a single page, to start doing something, document the data, see how the trends are, and then decide the way forward in our own country. So there are a few questions from the audience. Nitya, Shanti Ganeshan, Kavita Srinivasan, Prasanna Amanda. Rest of you, keep your questions going. We will take them at the end of the session. So we bring you the last of the presenters for this evening, none other than Dr. Sita Ramamurthy Pal. In her CV, I would want to point out one thing. She is an RCR diploma in advanced OBG ultrasound. Okay, obstetric ultrasound, as has now been defined as our sixth sense, so crucial in complex and high-risk pregnancies, such was deliberated both by Chinmayi and Uma. There are so many things that we need to know accurately. And once again, we urge people like Sita to bring in the expertise and the quality training into our country with the organizational position that you will be required to hold in the near future. Managing committee member of the Bengal OBGYN Society, East Zone Coordinator of Imaging Science Committee of FOXI, member of the RCOG East Zone, Representative Committee, Honorary Treasurer of Fetal Medicine, Clinical Secretary of ISOPAP Kolkata Chapter, and a busy consultant, the Fetal Medicine and Obstetrics Unit at the Apollo Glenealis Hospital at Calcutta. When I launched the YouTube channel called Health for Her, there is a section I want to introduce for the youth in the backdrop of the World Population Fortnight that has been celebrated in the last couple of days, ending end of this month. And there we have titled the youth section as Sita Speaks, because in the Ramayana, Sita will not speak. And we want the new generation Sitas to speak up on everything related to sexuality, family planning, contraception, mental health, and a lot of things that the youth may have. So here we present to you Sita speaking on another very, very important issue of how, when, why, and what the time for intervention. When everything has been managed very well, it is just that one decision of the timing, which may just really, as I said before, give you the most brilliant of the outcomes or the most dismal situation. So dear friends, whilst you are pondering on Sita's deliberations, we urge you to throw some more questions, which will be handled right at the end of her presentation. Sita, please.
Thank you. Thank you. Thank you, Dr. Hema, for that kind introduction. And thank you, Oma, for making me part of this panel. I'll just make it screen share. Am I audible now? Yeah. Yeah. Hello, is it clear?
Yeah, very clear, very clear.
Thank you, thank you. So as Madam Hema said, and Dr. Uma also said that everything about diabetes that we do, we control, we take care antenatally, preconceptionally, during the early antenatal period, we screen, but eventually when the time comes to deliver, then that is a big question that we need to answer as to provide these women with the best optimum care that we can, or healthy baby that we can give them. And this is me for you, as I've already been introduced. So what we know about diabetes and pregnancy, we know that it increases the risk of perinatal morbidity, mortality, and as we've seen, a whole lot of congenital anomalies, especially if there's poor control. And the risk is highest with type 1 diabetes mellitus, followed by type 2 and GDM. All GDM also has its risk, but the risk is highest with pre-existing diabetes mellitus. And despite improved glycemic control and declining rate of anomalies due to good preconceptional care, perinatal mortality in these women, preterm birth, large for gestational age, shoulder dystocia, and especially stillbirth still remain high, and especially more among the pre-gestational diabetes. So what are the delivery options? Like a lot of issues in diabetes, this also is an unresolved controversy. And here we need to decide about the balance between increased neonatal morbidity of delivering a late preterm and early term versus having a IUD in our hands and fetal mortality. Because especially late preterm and early term deliveries, they include respiratory problems, as we know, especially in these diabetic fetuses, as well as other metabolic dysfunctions which are characteristic of the preterm infant of a diabetic mother. And when you leave it to term or beyond that, it increases the risk of fetal demise, fetal overgrowth, and associated problems, as we've heard, with shoulder dystocias and birth injuries. And the risk of intrauterine fetal demise in the third trimester usually appears greater than that of the neonatal death. So that is the important time when you need to concentrate and decide as to where will be the deciding line there. So clinical decisions on delivery is complex, and it depends a lot of maternal factors, fetal factors, and obviously the risk of adverse outcomes that we are most worried about, as we've just seen. And currently, there is no consensus or guidelines regarding optimal timing of delivery regarding women with gestational diabetes or with pre-gestational diabetes. But the clinical practice actually varies between service providers, and depending on the infrastructure you have, what neonatal backup you have, what sort of place the lady comes from, how far she's from the hospital, and etc. And in fact, a survey of clinicians on the management of diabetes with GDM was done, and they showed that women with diet-controlled diabetes who were there, 10% would deliver them at 38 weeks, 14% at 39 weeks, and 57% at 40 weeks. This was in women with diet control GDM. And with medication, that is if they were on, usually I would presume insulin, then here 28% at 38 weeks, majority hovering around 39 weeks. So what is the problem? Obviously, we've seen in all these women, as we've seen from before, they have incidents of spontaneous miscarriages, congenital anomalies. We've heard that they have a different growth trajectory, and especially if there is vasculopathy, they will have a fetal growth restriction. But if it's poor control, and especially needing a lot of insulin towards the later stages, they would have large for gestational age and macrosomia. And especially because of that, if they have polyhydramnios, they could have spontaneous preterm births or iatrogenic preterm births because of the concerns the obstetricians can have, or a stillbirth, which is the most worst outcome expected. So as we've seen the growth pattern, they can be either small for gestational age and accelerated growth with expected weight above the 95th centile, but mainly important is the growth trajectory. And we've seen that the HAPO study has shown the clear continuous association between increased maternal glycemia, hyperinsulinemia, and infant birth weight. What about stillbirth in these women? So as always, the hyperglycemia and hyperinsulinemia is the main problem in these women. And this results in increased oxygen consumption with decrease in the oxygen content in the red blood cells. And the fetal hyperglycemia actually results in increased hepatic glycogen storage, which leads to chronic hypoxia, acidemia, and subsequently stillbirth. Now, though the relative risk is high in women with gestational diabetes mellitus, the absolute risk is actually low. And in fact, a study in 2017 showed that in type 1 and type 2 diabetes mellitus, though the stillbirth rates have declined despite little changes in gestational age at delivery, which means that factors improved surveillance or tighter glycemic control targets are more important than actually the timing of delivery that at what gestational age that we use. So what are the predictors of stillbirth? As we've seen, the maternal blood glucose levels and BMI have the most strongest association. This was again study done in 2019, which said that the glucose levels and BMI had the strongest associations. And babies who had a birth weight less than 10 centile, with maybe small for gestational age or associated FGR would have, mainly FGR, would have a 6-fold higher risk. Whereas the babies which have a growth trajectory and weight above the 95th centile have a 3-fold higher risk. And a significant proportion of these stillbirths occur at after 37 weeks, which is, they have actually said it peaks at around 38 to 39 weeks. So what are the tools for fetal surveillance? We've seen that we need to do serial growth scans, Doppler assessment, amniotic fluid assessment, and biophysical parameters, not forgetting the baby's movements, fetal breathing movements, and the cardiotocography as we do as an antenatal assessment. So again, not to repeat it again, but usually we would do a growth scan every 4 weeks, especially the one at 36 weeks, to see what the growth trajectory is there. And obviously the frequency will depend upon what are the dynamic risk factors in these 4 weeks that's happening because of a glycemic control or the findings that we find on the ultrasound. I'm not going into detail of all this, but as we've seen that the macrosomia mainly occurs, which is seen on ultrasound, is from the 24 weeks onwards. And especially if you have to predict the birth weight in order to deliver these women, ultrasound is not very sensitive, especially when the weight goes more than 4 kilos. The sensitivity is anywhere ranging from 33 to 83%. And sometimes we also look at these methods of evaluating macrosomia or the problems they might have delivery, but they're not very sensitive. But there are fetal anterior abdominal wall thickness, which can be done in the standard AC view, or sometimes you can use other measurements, but they are not usually practically used or useful. Doppler assessment, as we've seen, as we would do for other babies, are not very useful here because the problem is a metabolic one and not vascular. So you will not have those typical Doppler abnormalities as you will see in a woman with a preeclamptic or a placental insufficiency where you have abnormal Doppler changes. But if there is associated FGR because of other findings for cofactors, then you will have Doppler abnormalities. But per se, diabetic women will not show, the fetuses will not show the abnormalities in Dopplers. Amniotic fluid, it's not a prognostic value. You just have to see what are the signs of polyhydramnios there, and sometimes that could be the first indication in these women to check for them for developing gestational diabetes. So regarding timing of delivery, what is the evidence so far? at any with any sort of problem in obstetrics, whenever there is confusion or there is a dilemma, you have a lot of studies and a lot of evidence. So going from what we have so far, and whatever the studies have gone through, they have some have been with gestational diabetes, some have been with type 2, but most of them have been combining the two. So there has been no clear cut, and we'll just go through a few of them. Started off in 1993 when Kiosk et al. Said that in women requiring insulin, a randomized trial of done, one of the few randomized trials that were done, of induction versus expectant management, and they said that infants born following expectant management was significantly larger rather than infants born following induction of labor. Then in 2011, there was a study which said that iatrogenic delivery at earlier term gestations reduces the risk of neonatal complications in women with gestational diabetes mellitus. NICE 2015 said that in women without complications, that is in type 1 and type 2, an elective birth by induction of labor or by select, if indicated, that the cesarean for obstetric reasons would be between 37 and 38 weeks of pregnancy, and elective birth before 37 weeks if this lady had complications. With gestational diabetes mellitus, you can wait till 40 complete or 41 weeks and consider elective birth earlier only if she had complications. There was a trial in 2017, the GINXMAL trial. It found no significant differences in cesarean delivery rates or the neonatal morbidity rates between women with GDM randomized to induction or expectant management between 38 and 39 weeks. So you could do either. They didn't find any difference. There was another randomized trial in 2017 which showed a controlled trial of induction at 38 weeks versus 40 weeks in women with insulin-controlled gestational diabetes. Mind you, these are women gestational diabetes with insulin. And they again found no significant differences for cesarean delivery following induction, or these women at 38 versus 40 weeks of gestation. Then Cochrane came in 2018, said that in women with pre-existing diabetes, they attempted to determine the optimal timing of delivery, but they concluded there was insufficient evidence to answer this question. They also said about GDM that there was insufficient evidence to clearly identify if there were any differences in outcomes of these women and their babies, especially when elective birth is undertaken compared to waiting for labor to start or until 41 weeks if all is well. So these words are all, you tend to, but the bottom line is there is no conclusion. Then a study came in BMJ in 2019, and they said that in women with pre-gestational diabetes, induction between 38 and 39 weeks was not associated with an increase in section rate, but there was an increased incidence of neonatal intensive care admissions, jaundice, and hypoglycemia compared to expectant management. The ACOG committee opinion for GDM in 2019 said that deferring delivery to 39th week is not recommended if there is a medical or obstetric indication for earlier delivery. So basically, if there is a problem, you have to deliver before 39 weeks. So bulk of the literature that we all have seen so far mainly says, it supports that you have to deliver 38, 39 or 40 weeks. So finally, when we come to our own Government of Health, Family Welfare, which has given its guidelines in 2018, and they have suggested that GDM pregnancies are associated with delay in lung maturity to fetus. So routine delivery prior to 39 weeks is not recommended. But if a pregnant woman with GDM with well-controlled sugars has not delivered spontaneously, induction of labor should be scheduled at or after 39 weeks. And in women with poor blood sugar control or those with other risk factors like hypertensive disorders, previous stillbirths or other complications, they should be delivered earlier. And they have clearly said that the timing should be individualized by the obstetrician. But in case of fetal macrosomia, consideration should be given for a primary cesarean section and 39 weeks to avoid shoulder dystocia. So this is our own guidelines which we can follow. So generally, when we look at these women, what are the factors that will influence timing of delivery in gestational diabetes mellitus? So if you have a woman with a past obstetric history, that she has a previous loss, previous history of macrosomia, there is loss of fetal movements, there is a growth restriction, there is uncontrolled diabetes, she's needing more insulin, and regarding, as I said, the social factors, whether there is a backup available, you would consider delivery less than 39 weeks. But if all is well, that is, there is no problem, she's well controlled, there is good growth going on, and you have all the facilities, you could deliver, you could wait up till 39 weeks and then decide with her about induction and so on. But within pre-gestational diabetes mellitus, the guideline recommendations are varying. We have seen so much of variation, and it's really poorly supported by high quality evidence. The argument in support of elective delivery before 39 weeks is mainly because of all the risks that we worry about, the risk of stillbirth in these women. And that's why you need more studies to characterize other factors such as pre-pregnancy BMI in these women, glycemic control, sonographic parameters, and the type of TDM that can be used in what we need for timing of delivery. So the takeaway messages for me here is that the decision on clinical management should be ideally based on definitive evidence obtained from randomized trials, which is obviously difficult with these women. So that's why it is very complex, especially when you decide the actual timing of delivery. And so you must balance the risks and benefits to both the mother and the fetus. And appropriate clinical decisions must be taken, which are best individualized according to the clinical condition, its consequences and outcomes, and last but not the least, the woman's consent and her informed choice. Thank you so much for your patient hearing.
Thank you very much, Sita. As
Thank you.
We can guess from the 200 plus audience who are viewing the show with many, many questions posed on a variety of the issues that have been raised by all the three speakers, but more importantly, many, many compliments that the talk crisp, precise, insightful, and very meaningful. So thanks on behalf of Shield and myself and all the audience yet again. So the last set of questions will be asked first to the last speaker. So Sita,
yeah,
get ready. So there is Uma Devi who asks about steroids in GDM. How and what is your opinion about giving it, even on a prophylactic basis, presuming anyone can go into preterm labor? That's unpredictable.
Absolutely. So with steroids, at least the only positive evidence we have anything in obstetrics is the role of steroids in lung maturity, which has been proven so far. So when you give steroids, whenever you give it, be it for growth restriction or for whatever, whenever you deliver because of other reasons, the timing is important. You should ideally be giving within 1 week of delivery, of contemplating delivery. That is, if you're planning to deliver within 1 week, or you think the mother might have to deliver within a week, it will be best effective during that time. And if you have to give, obviously there is a concern that the sugars might go vary. So if you're able to manage that on OPD basis, it's good. But if you think it's not and she's already needing higher insulins, it's better to keep them indoors, inpatient, and then monitor the sugars along with steroids. But you must give them, because as we've seen, especially in women with GDM, there is a delay in lung maturity even when you deliver them around 30 weeks. So steroids will have a definite role in that.
So there are both Manjula and Anita Agarwal have raised the question on what are the risk factors for sudden fetal demise? Can you predict an IUD in an ongoing GDM pregnancy?
That's a very important question and very good question, because as we've seen, the fetus does in diabetic mothers, if there are no other confounding factors, that it's usually not, we don't have any absolute predictors like we do in normal FGRs, where we can say that the umbilical artery is going abnormal or it's getting reversed. So in these women, if there is a sudden increase in growth in insulin requirements, and then you have to keep monitoring them in the later, as you said, a growth scan at 36 weeks. And then you keep an eye, listen to the mother, what she's saying, if she's having reduced fetal movements, if there is, and then if you need to monitor them, you can do it twice weekly and a CTG and monitor them. So as such, we don't have any, accurate predictors that this is what happens, you have to deliver them. It can happen suddenly because as I said, the stillbirth here is more metabolic than vascular. So, so that is why it is difficult to predict in these women about the occurrence of stillbirth. So we have to go on our clinical judgment and decide.
Sita, one small follow-up question to the first question about the steroids, dexamethasone or betamethasone, or any?
Both you can give, but obviously the betamethasone is not very freely available, so dexamethasone can be given.
Did Uma wanted to add something?
Yeah, she wanted to say.
I just wanted to add in the context of the IUD to everything that Sita said. The ones where we sometimes get lulled is those who had poor control initially. Now, if you take this woman who, the sweet one that Chinmay presented, if she had booked with an A1C of say 8, for example, and we would have done everything we can to get her into good glycemic control soon. But the fact that she had hyperglycemia in the first half of pregnancy, we shouldn't take our foot off the pedal and get lulled by the fact that her sugars are better later, because there is some data that poor glycemic control early on in pregnancy may increase their chance of even stillbirth later. So as Sita said, the evidence on all of this is very minimal, but that's something that we need to keep in mind.
Okay.
Everything goes okay, and all of a sudden the demise, and 3 hours ago she's had her ultrasound scan. That is that all that we can say, yeah? Because we've explained the complexity of this whole, the phenomenon that, sometimes it is, but all these little points, if you do pay attention to, you'll be much better than, yes, Sita?
Yeah, the very important thing is the stillbirths occurring in later gestations. It's mainly the brainstem which is very sensitive to hypoxic episodes. So it is not the acidemia which kills. But it's the brainstem, because the brainstem is more mature. In a younger fetus, the brainstem is not that mature. So even if hypoxia occurs, it will take time. But it's in these late term fetuses, the brainstem is very sensitive to hypoxia, and that brainstem can be monitored by when we're doing an ultrasound. We look at fetal breathing movements. We look, not the entire biophysical scoring, but generally the growth, the fetal breathing movements, and very importantly, the CTG. Because the CTG will actually tell you, if you have any concern on the growth, you could call them for a CTG, and that will tell you if it is going. Then you can try and predict. You might not be able to avoid all of them, but try and avoid a few of those stillbirths if we can.
So there is Dr. Chetna Ramani, who is fully focused on hypoglycemia. It says if repeated episodes of hypoglycemia happen, does it imply impending death? And how to manage these hypoglycemic episodes? Uma, I'll just come back.
Yeah, no problem.
Yeah, so, there's always a concern with this ladies needing insulin regarding hypoglycemia. But I think hypoglycemia can be much more severe if she's, going to lose her, she's going to get she's going to get, she's going to get hypoglycemic attacks and swoon over us. But generally, the baby tends to be quite resilient about all this. So we're not really expecting, unless the sugars plummets down to 40, 50, where we're going to have an hypoglycemic coma sort of things. But I don't think otherwise we have to be too worried. But more importantly, the mother should not injure herself and, care that way. Yeah. I would think. If Uma wants to add something on that.
Yes, Uma wanted to add something in fact,
the previous context, just to say that, yes, when we have a stillbirth in a diabetic mother, we tend to think only of the diabetes, but we can't forget the fact that other causes of stillbirth could be operational. So we need to ensure that our complete evaluation that we would do for any stillbirth is done. Don't say this is the diabetes that caused the stillbirth and then let it be, because that's the only point I want.
Uma, I do remember that you had spoken at length about the positioning of metformin at the before, at the start, throughout, etc. In a great debate that we had at Bangalore at the conference. So Dr. Rajani asked, metformin and inositol. What has been your experience with use of these for, those who cannot get under control with just diet and exercises alone?
So we tend to use metformin. It's quite useful for, especially if the woman starts off with a higher BMI, higher insulin resistance, because the way metformin works is by increasing insulin sensitivity. So you may need to add insulin, and I think that's the strongest argument that lot of endocrinologists and diabetologists tend to give against the use of metformin.
Uma, they always keep on arguing with us. Should you involve an endocrinologist? Most by the audience. Arey Baba, every time they come and they confuse us. What do you?
So I think there is a category of women who you would involve them. Those are those where the control is very bad, or you need to give multiple doses of insulin. Then you definitely need their input. But I think this category of women you can manage well with metformin, and it may actually have some good metabolic impact on the fetus and the fetal adiposity as well. So
if you sprinkle myo-inositol, D-inositol, vitamin D, what will happen?
We have to wait and see. We have to wait and see what happens. We have to wait and see what happens actually. At least in pregnancy, we need a little bit more information before we can say use it. In PCO, there is data that, you know, when you use Inositol for insulin resistance, it works. But before we say use it liberally, there could well be a very good potential role, but we still need more data to say that.
Yeah, so since you've said that, and Sita sticks to only insulin usage, Aarti has asked, if the patient is on insulin, how you will monitor her sugars? You'll monitor it 6 times and every day, or how every woman will be able to do this, Sita?
Well, that is the importance of counseling that we need to do for these women, because it's very important to make them realize that insulin doesn't cross the placenta, first of all, so it doesn't harm the baby. And secondly, if you're needing to monitor needing insulin, and even the most concern is that these women say that I'm taking insulin, despite that my sugars are going up. But because that is a natural pregnancy being a hyperglycemic state, the demands does go high. And so needing higher levels of insulin does not mean that, you know, you're not doing well. You have to counsel them, and you have to tell them to monitor at least fasting once, at least post lunch and post dinner. May not be every day, but to start off with one day fasting, 1 day post lunch, 1 day post dinner. And depending how the sugars are, then we tell them to keep a book chart, and then be more frequently if the sugars are not under control, and maybe less often if the sugars are very well under control. But monitoring, home blood glucose monitoring.
So this is a lot of homework you're giving to this patient on insulin, right? Because she has to keep the book and she has to keep on writing. So that's a great part of her homework. So if we have happened to only manage with the diet or metformin or any other supplementary stuff that we've given her, then your monitoring schedules also will be a little bit relaxed.
Relaxed, absolutely, yeah.
And
we can start off with we can start off with a baseline blood sugar fasting or whatever. We decided to put her on nutritional therapy, and the reason we put her on metformin and the HbA1c, and then monitor her depending after 3 weeks or a month or so to see how she's doing, depending on what gestational age we picked it up, because we don't want to leave it too late also to start off insulin.
So on this section, Dr. Mitra Saxena asks, what's your final verdict for the timing of delivery? When will you do it?
So for GDM patients, well controlled, no complications, I think you can wait safely till 39 weeks. If all is well. If they're needing insulin, and if their growth is any other problems, you might have to deliver before 39 weeks. And for pre-gestational diabetes, I think between 38 to 39 weeks. That would be my personal opinion.
Excellent. Uma, we swing back to you on Arun Madhav Barua, who asks you, fetal growth restriction. As you said, stillbirths, you don't imply only diabetes as a cause. There may be several other things. Similarly, he asked, for growth restriction also, there can be several other reasons, except apart from really very, very strict control and then the baby being tiny. So how do you look at those? And
yeah, so once you have a baby which is dropping growth, you have to monitor as you would monitor any fetal growth restriction. So you will have to monitor fetal growth and do a biometry in a 2 to 3 week range. And you have to look at the Dopplers and look at placental function based on the Dopplers, and the fetal response to this placental dysfunction also based on Dopplers. So if you do a multivessel Doppler, that will give you a guide. So if you have a baby which is started, so look at the trajectory. If you have a baby which is small at 28 weeks, go back and see how this baby was at 20 weeks. If this baby was just hugging that 10th centile all the way, then it may not be placental dysfunction. It may be a constitutionally small baby. So the approach to the approach to growth restriction does not change because the mother is diabetic, but we just need to keep in mind that a very tight glycemic control may have contributed to the smallness of the baby.
Again,
so we have to
the
keep
small baby, do you think you would have caused it by giving metformin? Does metformin give rise to growth restriction? That's another question.
So the evidence doesn't seem to suggest that metformin causes growth restriction. In fact, if you look at some of the studies, the advantage or the benefit of metformin has actually been a reduction in the incidence of preeclampsia in those GDM mothers who were on metformin compared to insulin. So
But
in some way, it seems to be reducing this inflammatory response and therefore, reducing hypertension. So if we are looking, yes.
There is a follow-up question on this itself. You are telling that metformin may not do much now, but the question that another delegate has asked, maybe this child, when it grows into adolescence, this metformin which you're given now will cause obesity then. Is that true?
So again, not true, because there is about a 10-year follow-up data from the MIG tofu trial. And there they found some interesting changes in the initial adiposity, that is between 1 year and 5 years. But by the time the baby is beyond 5 years, all this adiposity evens out. So there doesn't seem to be a change. But we must remember that just the diabetes itself and the hyperglycemia itself predisposes to some degree of adiposity change. So how much is the hyperglycemia and how much is whether it is the medication that we are giving, and how much is nurture, because this baby's diet afterwards and lifestyle afterwards also will have importance. So if you look for look at evidence and you look at MIG tofu, there doesn't seem to be an impact.
Yeah, because as per ADA 2019, they say metformin is known to cross the placenta. So what do you say about it? This is the key factor which caused us a lot of brainstorming when we were trying to amend the Government of India guidelines towards the positioning and use of metformin, because the endocrinologists battle for a direct change into insulin if it's not controlled by diet and exercises. And we as OBGYNs, we said, we have been used to giving metformin in PCO right in the first trimester, and we've not found any teratogenicity or serious implications. So millions of hyperglycemia in pregnancy, if all of them have to go on insulin, just imagine how much of surveillance that we will need. And both hyper and hypoglycemia, the management of that would cause a real challenge. One last question. Again, I'm coming back to Sita, because times Karthik Srinivasan has, somebody else has asked about what is your preference of insulin? If at all you have to give insulin, what will you give? You'll of course make a call to the endocrinologist. Finally, we've agreed to bring them in some. What would you're networking with the endocrinologist? What does he say, or what do you feel?
Basal insulin to start off with, basically, and then we can add on as to the short acting insulins to add after dinner. Basically, it can have that.
Yeah, usually what happens is, even it'll be worthwhile striking base with your endocrinologist physician for the first time, because then they will not blame you for not starting the right things at the right time. So then when you do that, your whole duty will be to see whether it is meeting the targets. And if it's not, you can step up, step down, either way, depending
on the sugars.
Yeah, what it will show. So we are back to Uma again. Karthik Srinivasan, what is your take-home message? Uma, I'm asking you this because you're involved with a variety of studies saying one thing or the other, as how the Government of India recommendations, which is quite different from the recommendations in the West. So what is your take-home message for screening method, the timing of tests, and cutoff?
Okay, I think so it comes again and again in every forum. I think timing of screening, there is no confusion. You screen at first booking. If they screen negative, you screen again at 24 to 28 weeks. We tend to screen closer to 24 to 26 rather than wait up to 28, again because of the prevalence of the condition in our population.
Yes, so Uma, I want you to say that again, because Nitya has asked, why should we do booking check for everybody?
Everybody.
Risk factor. So please emphasize that again.
Irrespective of risk factors, we have to screen all our pregnant women for hyperglycemia at booking.
Yeah.
Because we actually are picking up a large number of pre-existing diabetics in that process.
Yes.
And it gives us an opportunity, even to those who screen and come back with a normal sugar, to talk about diet and exercise. Because as I told you, there is no absolute cutoff. And that is why there was some other question there which says sugars are fine, but the fluid is high and the baby is high. That level of glycemia may be big for that baby. We don't know. So there is, gives us an opportunity to educate them on exercise and diet. So screen at booking for everybody, screen again at 24. I know the guidance says up to 28. I would actually say 24 to 26. And then if you have somebody who still you are worried because there is a strong family history, or she's obese, or suddenly the baby's growth is going up, then you can screen again at a later point in time, 32, 34 weeks, whatever. So this is this timing.
So this answers Deepa Dorai's question also, because she too has asked what's the right time to screen in the Indian population, and all that Uma has said applies to our population because our ethnicity is our risk. And there is a question by Shanti Ganeshan about cutoff for termination. Chinmay.
Cutoff for HbA1c. I was
Yes.
interesting. The question is interesting, but madam, I would feel HbA1c is only a screening test which tells us that the fetus is at high risk of having the effects of pregestational diabetes. So I don't suggest that we should use HbA1c as a indication to terminate the pregnancy. HbA1c is an indication to follow that fetus very carefully, counsel the parents well early in pregnancy. If they do not want to take that risk, if they do not want to do that, that's a very individualized personal decision. It can't be taken as a HbA1c based decision. But for the general population, please do not use HbA1c as an indication to terminate a pregnancy. Anything less than 10.1 is reasonably good. More than 10.1, high risk for fetal anomalies, and therefore follow it up like we discussed in the discussion. The first trimester, second and third trimester follow up.
Yeah. I'm forced to go back to Uma Ram again, who is leading this entire concept of this webinar. Again today, the last bunch of questions which are suddenly emerging, there still seems to be a confusion about which test to do, when to do, because somebody says, I do for everybody at 16 to 18 weeks. Is that okay? Somebody else is saying, I do the fasting and HbA1c, it's okay. Someone else is also commented, HbA1c in the second trimester, what relevance does it have? So I still feel many gynecologists do not do the challenge test at all, is the other comment, which means, and also the recent NHFS data has shown that we want 100% of our pregnant women to be checked at least twice in pregnancy. One is at booking. If she presents herself within the first trimester, and if you delay the test well into the second trimester, you lost the opportunity of picking up somebody who would have benefited from the advice you would have given her about the lifestyle. So the kind of test that needs to be done, and still there is a confusion whether 75 grams, 2 hours, you take 130 as the cutoff or 140 as the cutoff. I'm raising these questions on behalf of the viewers today, so that one last time I want Uma to clearly define the Government of India and the FIGO guidelines for our country go on one stream, whereas there are, you as a consultant, depending on the settings that you are dealing with, you have the liberty of following any of the guidelines which will ensure that you do not miss any case which deserves attention. That is actually the bottom line. Uma.
Yeah, no, I agree. That's the bottom line that we screen. So the confusion, if you're going to do a glucose challenge, then the cutoff is 140. There is no confusion about that. Now, I would reiterate that the important thing is to achieve screening. If you are in a population where you cannot bring your women fasting and therefore you choose not to do any screening at all, that's a very big disservice. So the Government of India guideline recommends that we do a non-fasting glucose challenge, give a 75-gram load irrespective of the fasting state, take a 1 hour value and use 140 as the cutoff. So it's perfect that now if you look at the FIGO guidance, the FIGO guidance says that this can be done in a context of India because we have a large population where it is not possible to bring back people fasting. But if you are in a practice situation where your women are willing to come in a fasted state and you want to go with the general FIGO guidance, which is the non-fasting 75 gram GTT, and do 3 samples fasting 1 hour and 2 hour, and then use the IADPSG criteria to make a diagnosis of GDM. And if that is feasible in your practice for all your population, then at booking you do a fasting and a HbA1c, and at 24 to 28 weeks you do a fasting GTT. What you do not do is don't do anything at all, or do a glucose challenge in the first trimester and then do a GTT in the second trimester. So you need to use the same screening test on your population across the board and use the appropriate cutoff for that, because we see a lot of people, they use a GTT but they take 140. If you're going to use fasting IADPSG, then the values are different, 180 and 153. So you have to be sure of the appropriate test, and the guide, if you're using the glucose challenge, please use it in the first trimester and in the second trimester, 1 hour in the non-fasting state, and then take 140 as the cutoff. I hope that is clear.
Yes, see, I'm quite alarmed and surprised that there are ever so many questions on the screening process alone, because first vision should be preconceptual, early in conception, or if she presents for the first time in the mid trimester, any time that she enters a healthcare provider, this has to be high on your mind, and you must not use an opportunity to check on her glycemic status. That's point number 1. The second thing is, I was just coming to the NHSF data, which says, as on today, even with so much sensitization, 2014, remember, the government guidelines came in because we thought at least let people not make an issue about patient not turning up in the fasting state and not willing to give 4 samples, etc. So just let's use the simplest of the thing.
Exactly.
And that, as per the recent data, good 6 years after that recommendation has come, as on today, on an average, only 15%, 15.8% of our women are being tested, even with the single step test. That is the recent data which has come, which means that we have a long way to go. And at least we urge, because this is the government recommendation, but 60% of our patients are coming to the private setting. And this survey is overall, both public and private. And if we are not even testing the 85%, we are definitely missing out on our opportunity to do our best for these women right across the country. So we said, as simple as whenever she arrives at booking and in repeat and mid-pregnancy, do not worry about what she's eaten or not eaten. 75 grams, and at the end of 2 hours, she gives 1 sample and it's 140, and that's all you got to remember. So if she's already proved positive in the first trimester, that means she cannot be challenged anymore with sugars.
Yeah.
We have declared that brisk insulin response is not there in her body because of interference with the placental hormones. So you cannot repeat it, because there are some people who pick up this early, but again they will test in the mid-pregnancy with again challenging with glucose. That's a no, because you have to really strictly guide her for the diet and exercise pattern, and emphasize that it's not only pre-pregnancy and in pregnancy, but please, my plea to you all will be to expand the testing so that you do not miss out. And for different segments in your own clinic, do not use different tests and confuse yourself and confuse the lab person and everything. Just stick to your institutional protocol and align it with government protocol and the FIGO guidelines. Do that for 100% of your patients. And if you do discover, then you know how to manage them, because some brilliant presentations have happened today. But after delivery, as how we say, take home message, take home baby, take home mother, everything is okay, but bring her back. Bring her back at 6 weeks for a repeat test, and bring her back every year for a long-term, care on her sugar status and her BP, because PIH is often a comorbidity, so that presents a challenge. So gynecologists should be the point of contact forever after a GDM case who has delivered with you. You can't ignore her for subsequent years and say that she may come back with some menopausal problem sometime. By the time she may be a full-blown diabetic, 2 to 5 years, it converts into type 2. So this is again a point that we need to pay attention to, because Uma already said NCDs. This is again you reap as you sow. So if you sow the seeds of hyperglycemia environment and the fetus is programmed in a way that we will have a tsunami of NCDs for the generation next as well. So these are the clear take-home messages. I hope that you will test every woman, irrespective of the risk factors. You will test her at booking and in mid-pregnancy, irrespective of her meal status. And if it is simple enough, please do at least glucose challenge single step. And if you want to do, an extended test like in the West, if your setting can manage to implement that, then yes, go ahead and do it, but do it for everybody. At least 2 times. The first time, because we have not got an opportunity to screen the entire population pre-pregnancy. So at least when she comes, you must, use that opportunity to test her. One question to Chinmay again. It's a question which Uma read out actually. Just, we are talking about so much about the values, but you managed to be well under control. Just some finding is not okay, but you are landing up with a situation of polyhydramnios. Her AFI in the very next visit, 24 weeks you've done the test, but 26, 28 weeks, AFI is 25. What explains that, Chinmay, and what would you like to do?
Ma'am, if it is because of poor glycemic control, in addition to the polyhydramnios, I would expect some degree of macrosomia. It may not be macrosomia by definition, but like Uma ma'am said, we are looking at the growth trajectory, and therefore the centiles would have suddenly spiked up. So if that has happened, then we would think this is because of poor glycemic control, and she needs more support with her glycemic control, which may mean that she might be needed to be started on insulin, even if her values are little borderline on whatever medical nutritional therapy she's taking. Maybe she's a candidate to start insulin, and we would discuss that with the endocrinologist. However, if it's only polyhydramnios and the baby's growth is completely normal, nothing else happening, we should start thinking about the associated fetal anomalies which are leading to polyhydramnios, because we have already heard that in diabetic women there could be GI obstructions, or there could be tracheoesophageal fistula related issues. So we have to look at that aspect also. So I would again do a thorough examination of the fetal anatomy and look at the growth centiles very carefully. If there is an acceleration in the abdominal circumference of the skin thickness, and this looks like a baby who's going towards macrosomia, then I would discuss a different type of glycemic control with the endocrinologist, because her values may be normal, but there might be some degree of insulin resistance still there.
Yeah. Uma?
No, Hema, I just wanted to say, because there are a couple of points here, people who have asked about fasting and PPBS as a screening tool. So I just want to reiterate again what Hema said and what I said earlier, that you don't use postprandial sugars for screening. It has to be a glucose challenge. Maybe when I spoke, there was an error, or in the way I mentioned 1 hour, GCT is 2 hours. So 75 gram non-fasting 2 hours.
Yeah.
And not a regular post-meal. You don't screen with just a regular post-meal sugar.
Also, what test would you use when you call her back at 6 weeks postpartum?
I think at the moment, when we call them back at 6 weeks, the guidance is still to do, international guidance is still to do a full OGTT. That it is an inconvenient test at that time, because they are, a lot of them are not fasting when they're breastfeeding overnight. But we see a fairly high degree of conversion to dysglycemia of some sort. So we need to do that glucose challenge at that point in time, and then take it forward. If you can't do it at 6 weeks, at least by 12 weeks it needs to be done, So we tend to tag them when they come with the babies for their vaccination schedule, and then advise that they get it done there.
So Nitya Srinivasan asks, Uma, what about screening with fructosamine test?
No, there is absolutely no, absolutely no value to screen with fructosamine for GDM. It's a difficult test to do, and it shows control over a very short period of time. In fact, I think there was a point about HbA1c done in later pregnancy as well. Yes. A1c you use for screening, if at all, only at booking, because it helps you. And the purpose of screening in the first trimester is to identify your pre-gestational diabetic. Therefore, if you have a high A1C or a high fasting, you can categorize them. Subsequently, in the management of GDM, HbA1c has very little role, as does fructosamine, because you are not going to wait for a 3-month change to be reflected or a 2 to 3 week change to be reflected. You need the control to be tight on a day-to-day basis. So,
yeah, you know, to my mind, Uma, the scenario in the whole country, if you take and if you go by the data which is already presented to us, if we reach at least to the level of 80% of our pregnant women, because how 100% we are testing the hemoglobin, 100% we are testing the blood group and RH typing, but then 100% of our women, okay, we are not even expecting that. At least 80% of all our women are tested with some kind of a glucose challenge, and we do not miss even a single case of hyperglycemia in pregnancy. Then I think then we can talk more about what more we can do with this subsect of women. So in the last closing remarks, I would want each one of the speakers today to give their key message. If I were a consultant and I had to handle a whole range of Indian patients who are, which means all are at high risk. That means I'm handling a whole sea of high risk patients for hyperglycemia. Chinmay, what would be your advice?
Ma'am, see, I've been following the discussions very closely, and all the discussions have been about how to screen the mother, how to manage the mother, how to ensure hypoglycemia, avoid hypoglycemia. But remember, pregnancy is about the outcome of pregnancy being a healthy child being born. So don't forget the fetus. And while we are doing this constantly about the mother throughout, please make sure that you're following the final goal of that pregnancy carefully. So fetal assessment has to be very carefully done in these women. Like you said, they're all high risk, and many of them are not even getting tested for the hyperglycemic status. So it's very unfortunate that we are detecting diabetes in our population after a spina bifida, after an anencephaly. And I think like that pyramid has to turn around completely, because most of the time we find a fetal anomaly first, and then we do the maternal sugars, and then we find that she was hyperglycemic at that point. So my take-home message, unfortunately, I'm a bit myopic on that issue, but it has to start with the fetus and like be focused there. Of course, the mother has to remain hyperglycemic, but then close surveillance of the fetus and correct aneuploidy assessment with the diabetic factor taken into account, because that again leads to erroneous risk assessment in diabetic pregnancies.
Yeah, there's so much to do, isn't it?
Yes, ma'am.
Because the fetus, the mother, with so much complexities, for now, immediate short-term outcomes, long-term outcomes.
Long-term outcomes.
Mother, what will happen to that baby forever in their life? So there is a lot of tracking that we have to do. And hypoglycemia, can you give 25% dextrose? Again, the same it is asking, and I'm envious of this Arun Madhav Barua. He's like, eating some tasty dishes in his own house. We've been getting house to avail his hospitality for hypoglycemia, and he's making sure he's hypoglycemic. Thank you, Arunda, for joining us. Uma, Sita, your message. Again, hypoglycemia, again, was a question raised as to, can you give 25% dextrose to manage?
Yeah, basically home remedies if it's possible, but if she's going into severe glycemia, hypoglycemia, we'll have to get her in and then manage with 25% Extreme.
So your advice to
Yeah.
our
So
friends here.
my advice is these women are high risk, as all women are, but these women are especially at high risk. So be it lockdown or no lockdown, you have to keep a close watch on these women, and be patient as to hear them as to what they have to say, because all the time they might not be able to consult you, especially in the last trimesters of pregnancy where they are concerned, we are also concerned. So keep a watchful eye and do necessary ultrasounds required or monitoring, and if clinically judge them, listen to them if they have any, they're saying they're having reduced fetal movements, because that is the best judge sometimes, and decide according to clinically what suits you and the patient. And the baby.
So as many times and as much, the 360-degree turn around, and don't leave anything to a chance to get the best outcome both for the mother and the baby. Final words, Uma.
Yeah, so I think there's a lot to be done in this area, and as obstetricians, we actually are in the center of the whole problem, with the ability to influence not just this pregnancy, but the future of the mother and the baby. And I think internalize, and I would say three things. First, it's very, very important that we focus even pre-pregnancy to improve, because we've heard in all our presentations that the prevention starts before conception. Before that neural tube closes is when we can most influence the reduction in anomalies. So pre-pregnancy is very important. Early screening, screen consistently, screen everyone, monitor the sugars well and monitor the baby well, and always keep in mind that we are looking after both the mother and the baby. And simply because we have the ability to establish a rapport with this woman across 6, 7, 8 months, it is important that we emphasize to them, even during the pregnancy, the need to monitor sugars going forward. Because that's the only way, post-delivery, that's the only way we can actually translate our influence into reduction of NCD. And that's
Absolutely.
very, very important.
Absolutely. Again, practical obstetric Mitra Saxena reminds us that we are the first point of contact. So we are the ones to uncover or discover the hyperglycemic status in every pregnant woman. So behave responsibly, screen everybody whom you encounter, even without risk factors. And she did a fantastic session on labor room scenarios where issues like shoulder dystocia, because these are real problems. Though the threshold for deciding on a C-section is so low nowadays, with all these kind of complex management, you're just waiting for to get away with a good outcome. Somehow you don't want to take the additional stress of monitoring minute by minute and when to plan when. So that given the fact that yes, vaginal delivery will be shrouded with some challenges, you should also be equipped to know how to manage the challenges. So practical obstetrics, fetal medicine, imaging sciences, council who will have to look at strategizing the GCPR or good clinical recommendation practices with the leaders whom we see on the screen here. We do hope that you will occupy some strong positions and have a real strong voice which will translate into awareness and action. So we hope that not only the discussion this evening has triggered off many, many thoughts in each of our minds about how much each one of us can do to make the situation better, and collectively, with our thoughts synchronized and synergized, how much more we can all do together in this battle, not to let India become the diabetic capital of the world, and to put the generation next in the best of health. So one last time, thanking all our very distinguished speakers, Chinmay, Sita, and the chair of the AICCRCOG, Ram, the hosts for today, as in the Shield Healthcare, and of course, all our very delightful, very involved audience who really tracked the nuances. Why this? Why not that? And we loved it, because that shows 2 points that you really paid attention to whatever was said, and you're really concerned about what next. And we appreciate all of these. So Let's stay together, work together, and make this world a better place. Thank you very, very much for the kind opportunity to yet again place my thoughts in front of my very beloved colleagues and friends. Namaskar.
Thank you, madam, for wonderfully moderating this session for us. Thank you so much.
Thank you very much, Hema. I think she took the whole webinar into a different plane altogether. And I want to record my thanks to Shield Healthcare for providing us the platform and the technical support for the execution, and all of you wonderful audience who, you know, even after 2.5 hours, 2 hours, there are still over 100 people still there, and so many interactive questions, which made us think as well. And so thank you all very much. Thank you very much.
Thank you.
Thank you very much.
Thank you, madam.
There are very short thanks, by going to do the vote of thanks.
Yeah, Balaji
I think
decided
that's a
do
most
it.
practical take-home message. When we've already excellent time. Just say.
I thank
walk the talk.
for the
Walk the talk.
For the power, focus, and the energy Hema madam has shown till the last moment. Thank you very much. It is our pleasure from Shield to associate this program, and thank Dr. Umaram for giving us this opportunity.
Super.
I thank all the audience and the faculty, Dr. Sita and Dr. Chinmayi, for making this session very lively. Thank you very much.
Thank you.
Thank you so much. Thank
you.
you. Bye.
Thank you so much.
Thanks. Bye for now.
Bye. Bye.
Thank you.
Those of us who are staying with us, nearly 100 plus, there'll soon be yet another RCOG collaborative session by none other than Dr. Umaram. Watch this space in the second half of August. We'll see. Bye-bye.
Sweet space. Thank you, ma'am. Thank you so much, ma'am.
Thank you so much. Thank you.
Bye.
Bye. Bye, Chinmay. Bye.
Bye.
Thank you, Ma. Bye. I can't find my fingers.
Yeah, downstairs, right.
I had to change.